Yep, in the interest of time, we can start. This is about 4 o'clock on the dot Central African time. I'd like to welcome everybody and a special welcome to our speakers. I am Catherine Muyawala, the Bid Learning Network Coordinator and your webinar host. And as many of you know, the Bid Learning Network is a peer learning platform led by PATH. And today's webinar is actually the first in a 3-part webinar series about the experiences and lessons learned on the COVID-19 vaccine introduction from Africa. And these interactions that we'll be having in the next 3 webinars that we'll be having are intended to promote mutual learning and lessons sharing amongst the public, private, and international health practitioners, policymakers, program implementers, researchers, and academicians, just to name but a few. So just to, before we begin with today's business, I'd like to quickly remind everyone about the ground rules. In the chat box, would appreciate it if the participants typed in their name and their country where they're connecting from. And if you're a number of persons sharing the connection, would really appreciate it if you just put the number besides yourself, you just put the number. We'll put an example there. If Catherine is sharing the same connection with 4 other people and she's from Zambia, you just type in Catherine Muyawala, Zambia +4. We expect all participants to be muted and the videos to be disabled. I mean, obviously this is to, allow the discussants to speak without any interruption and also ensure that we don't affect the bandwidth for those whose internet connectivity is not very strong. Then in today's discussion, I think which is quite interesting and it's been divided into about 3 segments. We'll have a question and answer session after every segment. So in that case, we would like to invite all the participants. If you've got any questions, you can type them in the chat box and they'll be logged and answered during the various question and answer sessions that we've lined up, and where you'll be able to put up your hand and speak. And also to let you know that this webinar is actually being recorded, and the link to the recording will be shared via the Google Groups as well as the BID website. So back to today's business, which is on the introduction of the COVID vaccines in Africa. And we're getting special lessons from Cameroon. We know that the COVID-19 pandemic has taken the world by storm and it has disrupted the health services and it has increased morbidity and mortality while throwing the entire economic and social systems into array. And according to the World Health Organization, we know that globally, the pandemic has claimed over 3 million lives and with 143 million people infected. Can you please mute our speakers, please? Kindly mute. We're requesting everyone to mute. So as I was saying, globally, the pandemic has claimed over 3 million lives and more than 143 million people have been infected by the virus. But thanks to the WHO, UNICEF, and Gavi, the Vaccine Alliance, as well as the other partners who've been working tirelessly to support countries around the world, including over 40 African countries, to access the vaccines and prepare for the introduction. And Cameroon is one of those countries who are now deploying the vaccines. And today we get to hear from them and what the experience has been with this exercise. And to lead us in today's discussion, we're honored to have Mr. Mbainjai from the Gambia. He has been working in the public health since the year 2000, where his initial focus was on immunization, disease surveillance, and other public health related activities. He became the Divisional Vector Control Officer in the year 2006, and later on became the Senior Malaria Control Officer in 2011 and worked in that capacity for a year. He consulted for the Stop Transmission of Polio program in the Gambia, and also worked in Nigeria from the year 2013 to 2014. And he was assigned the EPI program in 2015 as a capacity building manager, where he was charged with the responsibility to strengthen the program. Bai is currently the Senior Surveillance Officer for the EPI program in the Gambia, and he actually holds a high national diploma in public health and a master's in Master of Science in Public Health Entomology. And he's also a peer learning advisor for the Bid Learning Network, a position he has held for the last 4 years. So a warm welcome once again to our moderator, Mr. Mbai, and to our distinguished speaker from Cameroon, Dr. Calvin Tonka. I will now give the floor to the moderator, Mbai Njai, to introduce the speaker and lead us through the discussion. Mbai, over to you.
Yeah, thank you very much, Catherine. Good afternoon, everybody. Good morning and good evening to some audience. As Catherine highlighted, my name is Mbai Njai. Just to quickly go through, we have our able speaker here by the name Dr. Calvin Tonga from Cameroon. Dr. Tonga is a nurse by profession. He for over 10 years experience in public health and data management, where he has held various public health portfolios, including vaccination, epidemiological surveillance, and health information management at operational, intermediate, and also national levels of the public health pyramid in Cameroon. He has a lot of experience in when it comes to immunization. He was focal point in public health activities in the Mwanko region from 2007 to 2011, where he also moved to head Puma District Health Office from 2011 to 2012, and then became data manager and surveillance focal point at the expanded program on immunization in Latoura region up to 2016. Dr. Tonga is currently unit head for planning, monitoring, and evaluation of the expanded program on immunization at Central Technical Group at the Ministry of Public Health in Yaoundé, Cameroon, where he oversees the collection, analysis, organization, consolidation, and dissemination of data, in general, data management aspect of immunization. He also provides staff training through workshops, supervision, and I think that's what he just told us that he was presenting, supervision and monitoring. And then Calvin holds a master's degree in public health and a PhD from the University of Douala. Ladies and gentlemen, this is the gentleman that we have in our midst here to talk to us about the COVID-19 vaccination. Maybe I will allow Calvin to say hello to everybody.
Thank you, Mbai, for the introduction. Catherine, Mbai, and all of the audience, welcome. I'm very pleased to be with you today.
Thank you very much, Calvin. As Catherine highlighted, we will be discussing about three topics here. The first topic will be the challenges being faced by Cameroon in the introduction of COVID-19 vaccine. And then we have some areas that will definitely, Dr. Tonga will definitely talk to us about their challenges. We will also entertain some questions as he highlighted. But we know that the COVID-19 vaccine is a precious item in the world, Dr. Tonga. And then countries definitely were asked to prepare for the deployment of this vaccine into their countries. And as part of the preparedness, because we knew that when the pandemic struck in 2019, the only hope that the world had was a potential vaccine. And then this has started coming out. And then as we speak, we have about 7 vaccines that are different type of vaccines that are being used in the globe. But like countries, we are definitely preparing. So what were the challenges when we are preparing for this vaccination exercise in Cameroon?
Thank you, Mbai. If I can summarize, everything is running after time because we are in an emergency context and everything is moving very fast. Yes. So we are really fortunate. It's really fortunate that finally we got vaccine. That is an additional asset for fighting the disease. And as other countries, we struggle to do our best in the very short length of time that we had to get to deploying the vaccine in the country. So the country, we had to develop our national plan for deployment and vaccination. And the short length of time that we had made it challenging. We also have challenges as for deploying the vaccine because, it goes very fast and we have to cover the country, or the entire country. Which is 475,000 square kilometer. And also, as another challenge, we also have, when it comes to population, the target population, we don't always have details for each set of the population. So it was a little challenging to determine the samples, the population size to be covered. And the last aspect, but not the least, is the adherence to vaccination, vaccine hesitancy as with COVID, and the development of social networks. You have so many rumors everywhere, and people are like, it increases the resistance to vaccines. So these are the 4 main challenges that we had to face. If I have to go now one by one, for developing the plan, many structures are involved. In fact, the fight against COVID is not just vaccination. We also have surveillance. We also have the territorial administrations relating to some rules that were set in place in the framework of preventing the spread of the disease. So many ministries were involved in the fight against COVID, and all these structures had to get together to develop the plan. So that it is a coordination challenge that we had to overcome also. And when it comes to logistics, we are used to deploying vaccines in the country, but the time within which we had to do this time was very short. And this was challenging as it put more pressure on the EPI team, and people had to work extra hours to get to the target as defined by the presidency of the Republic. And also coming to vaccine hesitancy, for example, as I told you, if you are in Cameroon and you go in social networks, be it Facebook or WhatsApp, there are many stories. Just of today, for example, we had a story of a woman who is a high rank who died yesterday. And what the story says is that she got vaccinated some 3 days ago, and yesterday she died. And everybody just is doing a direct link with the vaccine. And that is also, those are some elements that make some people reluctant to take the vaccine, including among the health personnel, because for now, we are at the phase of the priority target for now is the health personnel, people aged 50 and above, and people above 18 living with having some comorbidities, who are those who are prone to the severe forms of the disease. So these are the main challenges we have been going through, and we are doing our best to overcome this challenge and to meet our objective, that is reducing the burden of the disease and the pressure on the health system, because the pressure is much, not only in Cameroon. I mean, most countries in the world, COVID has set a very important pressure on the health system, and this is also exposing countries to the upsurge of other diseases than COVID. Thank you.
Yeah, thank you very much, Calvin, for that detailed explanation. But if I may ask, what type of vaccine are you currently rolling out in your country?
Okay, we are in the COVAX facility, and in the framework of this facility, Cameroon has received AstraZeneca vaccine. But before, we received 200,000 doses of Sinopharm vaccine that was given by the Chinese government. So these are the two vaccines that are presently being used in the country.
Okay, yes, thank you very much. And in terms of deployment, we know that like usually when we used to have vaccine introductions, there used to be this operational cost being provided by some of our partner agencies, and we have seen that like this is affecting some countries. I don't know in terms of financing the vaccine implementation at your own in Cameroon. How are you financing this rollout?
In fact, the government has really taken the issue serious, and there is a provision in the national budget for fighting against COVID. That is part of the funding that we're using for deploying the vaccine. We also have support from our partners, but we want to emphasize on the fact that the government really took it serious and is providing funding for deploying the vaccine. So in addition to what the partners are supporting in the country, this is what we use to deploy the vaccine and do all the training that is needed to make the vaccine available to the needy population.
Okay, thank you very much. That means that like the government is really committed to make sure that like everybody is vaccinated and all those things. So, but in terms of cold chain logistics, we know that like the Sinopharm and also the AstraZeneca are stored between +2 to +8 degrees, and then we also have the Pfizer that is also in place. Do you have any? What are your challenges in terms of ultra cold chain capacities?
Yeah, in fact, we took this into consideration when planning for the deployment of the vaccine. So we identify specific sites where the vaccine is to be stored. And across the country, we have 243 sites in the 10 regions where the vaccines are to be stored, and this will be fixed post for vaccination. Then we'll have some mobile teams, about 300 mobile teams that will go in hard to reach settings to offer immunization services. So we are also opportune that we are still in the cold chain equipment optimization platform. Fridges are being deployed in the country, and these pre-qualified fridges are priority for storing the vaccine, because we know some of this vaccine, in fact, this vaccine do not have VVM. We really make sure that we store them in appropriate condition. So these centers were selected on a very strict basis, including having a pre-qualified functioning cold chain and having a vaccination post where you could respect the prevention and control of infection for those who are coming for vaccination. So this was done in relation with the regional delegates and district medical officers to identify these spots over the country, and the list was validated by the Minister of Public Health, and this is where the vaccine has been deployed so far. So with the impulse of the Presidency of the Republic, everything went very fast, and all the sites so far have been supplied with vaccine, and vaccination has started over the country in the 10 regions.
Okay, that's great. Vaccination have started in the 10 regions of your country, and then are you having challenges in terms of turnout?
Yes. Now the first phase concerned her personnel, and much has been done the minister took his vaccine on the first day as the vaccine came. Now we have members of the government have taken their vaccine. They snap pictures, they shot everybody just to sensitize the population and tell them there is no, is nothing bad. And now that we are targeting health personnel, many people are getting vaccinated, but some are like, let's see what's happening before we go. So people are being vaccinated, but you know, there are some people who are behind, waiting to see for themselves before deciding whether they get vaccinated or not.
All right, that's excellent. Okay, listeners, just to remind you that you can also type in your chat your questions on the chat box. We'll also those who cannot, we will definitely allow you to ask some questions when we finish this issue of challenges. But let me come back to, because everything now, this world now is a global village now, and then like we know that like social media it's definitely having both positive issues and also negative in our health system, and this definitely is an issue that some countries are facing in terms of sharing information and all those things, and external forces from outside the country, like those in the diaspora and the like. For example, in the Gambia, we're facing some of those issues. Do you have any issues relating to social media being against this vaccination, or like?
Is it to me, Mbai?
Yeah, it's to you.
Yeah. Obviously, as I was telling you, I was just telling you what happened this morning. So at EPI, we've organized, we have a very strong communication team, and all of the EPI staff are involved in this communication. We are doing media, we are being vigilant on media to detect all fake news and all adverse message, to develop strategies to react on social media. We also have a Facebook page where we communicate everything concerning vaccines and specifically for COVID. We also have the communication department of the ministry also committed to this. And
Hello, am I being heard, or Calvin?
Yes, we can hear you.
Are you hearing Calvin? I lost Calvin.
Yeah, well, we've lost him as well.
We've lost him. Calvin, are you able to hear us?
Hello, Calvin.
It looks like he's dropped.
One of his
briefly. Yeah, I'm sure he'll reconnect.
He'll reconnect again. Okay. Whilst we wait for Calvin, and let me just share a little bit of experience from the Gambia, like just to keep you not to keep you waiting. The Gambia also, as we said, as Calvin just said, we are also part of the COVAX facility that definitely is eligible to be supported by 20% of the COVAX of the population by the COVAX facility, and we receive the AstraZeneca vaccine, which is about targeting about, we receive about 50,000 doses, and then we have definitely started deploying since on the 10th of March. One of the challenges we had was like at the initial stage, the vaccines arrived at the time when we even did not expect it at the country level, and then like people were just saying, we cannot keep the vaccines here, and people know that like the vaccines are around, and we need to roll it out. So we definitely need to fast track some of these things, and this definitely, the coordination aspect of it was a very, very big challenging issue, and then that's what definitely happened. Hello, Calvin. Calvin is back again.
Sorry, I got some network challenge. I was disconnected.
Yeah.
So thank you. You are getting me now. Yeah. So I was saying that we have, in fact, social media is a serious challenge, and most to believe what they read on social media rather than what is said in official information. So it's really a challenge. And we are doing our best also. We get in social media and we give out the right message. We try to reason with those we can reason with, and they also play an advocacy role. And we also got in relation with, we also got a partnership with many influencers who are very followed on social media to discuss with them and to present the real information to them. And these influencers now are spreading the right information to their followers. And this is a strategy that has been helping the program
all right, thank you very much. Okay.
With, social media. Thank you.
Okay, great. Thank you very much. And just to remind you that you can also type in your chat messages, chat questions on the chat box. And if you also have, if you want to come directly, you can just raise your hand and we'll give you the floor to ask a question. But we have a question in the chat box, Calvin, for you. And then like you already reported that you had an AFI case, which is definitely there. And then you said that like someone died just after 3 days after receiving the vaccine. But in terms of maybe you can shed more light on that. But the other question is, what do you have a platform to track the vaccination data? This is a question from Dr. Abdoulaye Gay. I'm sure Abdoulaye is from Senegal. Yeah. And he's asking. Yeah. So what are you doing?
Thank you very much, Abdoulaye, for the question. Definitely, we have a data tracking platform. We track data on vaccinated persons, their age group, their gender. We also track information on the vaccine, the vaccine use. We record everything concerning the vaccine, the type of vaccines, the batch number, the person received. We also have information on AFI that happens. So all regions, every evening, we assess, we collect data from all the vaccination posts. They are aggregated at district and regional level, shared with central level. We do analysis and we give feedback on data quality on questions where the information is not very clear. So we follow up on that because we also have to report to the minister on how things are moving in the field.
Okay, so from what you say now, you are not using any electronic system?
No, an electronic system is part of what we plan. We plan to use a tracker based on DHIS2 for recording information, but you know all this went very fast. So we couldn't wait for the tracker to be before deploying the vaccine. And for now, we are using Excel document to report information. There is a tool that Afro has shared with the country, and we are using this Excel-based tool to collect information while waiting for the development of this DHIS-based tracker to directly collect information. But we made sure all the information that are to be collected with the tracker are collected with this tool, because there is also a possibility to transfer the information from the DHIS, the Excel system that we are using into the DHIS when it is ready.
Okay, great. Yeah, that's good. So many countries like were caught by surprise when they said that like the vaccine is available and then it's coming over. Just like the Gambia, we also had that issue, and then we by then we definitely knew that like we definitely want to use an electronic system. The DHIS2 was there, and then we quickly engaged the IT guys, and then we initiated using the DHIS2 tracker. But along the line, because like devices like electronic devices to collect the samples and also data bundle, collect the information, and data connectivity also became a challenge, and some definitely had to abandon the system, the electronic system, and resort back to the paper. We are using them both, and then they were just trying to make sure that like if this one fails, we have the papers also running up and running. So now if they do not have the electronic system work up and running, they've referred back to the paper system, and that's what we are doing in the Gambia.
Okay.
We've gone past.
Yes, in Cameroon, we decided to draw lessons from the first part of using electronic system, because for testing, you know, we did much of testing in the surveillance part. So we faced these challenges, and we wanted to set in place a system that would not have the challenges you just talked about, and that is why it took a little more of time. Thank you.
Okay, good. We've gone past half the hour. I think, and then we have 2 more topics to deal with, and then we are just trying to get some questions along. If you still want to ask your questions, you can please type on the chat box, or you can raise your hand. I'll give you the floor to talk. From Mercy, Dr. Tonga, she's asking. She's thanking you for the information that you've shared, but asking, could you please provide any insight on any actions taken to mitigate impact on the vaccine rollout on other health services? Are you leveraging the same staff for providing the COVID-19 vaccine or such staff? And what are the plans as you continue to receive additional doses?
Okay, thank you, Mercy. What we did is, first of all, from the vaccine hesitancy that we saw, the strategy was not to negatively impact the immunization system when rolling out the COVID vaccine. So what we did is we selected the 243 sites where the vaccine will be available across the 10 regions. Out of about 3,800 vaccination posts that we have for routine immunization. This is the first, so we are not adding much pressure on the system because we have overall limited number of sites, and we also have phases. So we are going in phases. The first phase was targeting the health personnel, and there is a plan in each district for that, how the various health personnel will be received at this post and vaccinated. So this is to avoid much pressure on the system, not leveraging the same staff for providing COVID-19. And so that is the strategy for avoiding over pressurizing the staff in this. Thank you. Now,
okay, that's good. So because like in addition to this,
yeah, I see another question. I don't know if I can just answer from Jeff. The decision
Okay, go ahead.
Yeah, no, so the decision for delaying, in fact, when the newspapers and TVs and social media got full of this information about thrombohemolytic reaction after AstraZeneca, the country have already communicated about receiving AstraZeneca. So there was much controversy in the community at the point that the minister had to go back because in our country there is the NITAG. We have our NITAG, but we also have a scientific committee advising the minister on public health emergencies. So the minister decided to get back to this committee for the committee to steer whether we receive or not the AstraZeneca after this new events that happened. So the reception of AstraZeneca was suspended pending the advice of the committee. And when the committee now, the joint committee gave its position, we relaunched the procedure, and so far we've received 2 batches of AstraZeneca vaccines that are being deployed across the country. All 10 regions have already got the AstraZeneca vaccine, and the vaccination has started already in the country. Now, risk-benefits analysis between pregnant women and health workers. For now, the target that was decided by the Joint Commission is health personnel and people aged 50 years and above, and people aged about 18 years and above living with comorbidities. So these are the recommended target, and added to this, we also have defense forces who are to be vaccinated. We also have key public service staff that are very important for the critical functioning of the state. So all this is phase by phase. So first phase, we are now in the first phase, and first phase is health personnel and all those who are working, even if they are not health personnel, working at the front line, receiving patients in the hospital. And it is being extended now to people aged 50 and above, and those having comorbidities. This is the second phase we are entering in. with the reception of AstraZeneca vaccines. Thank you.
Okay,
now,
thank you very much. And then, like, she's also, yeah, how about frontline health workers who are pregnant? Are you vaccinating
yes, for
them?
now, the indication from what we're doing is for now we are not providing vaccines to pregnant women. So for now, it's a contraindication for the rollout we are carrying out.
Okay. So I think our discussions are already into the third strategies. Are you using to address some of these challenges? You mentioned earlier that you have two types of vaccine, the Sinopharm and also the AstraZeneca. And from there is not safety data yet to show us that like you can receive the two different antigens. So I'm asking, how are you differentiating the two? For example, if I receive my first dose for the AstraZeneca, and so I should not be receiving the second dose with the Sinopharm. How are you in terms of deploying these vaccines? What are the strategies that you are using to make sure that like you don't have a mix between these two vaccines?
The message has been clearly given that you don't mix the vaccines. So what we did with we first of all received the Sinopharm, and it's with Sinopharm where we started vaccinating. And what we did is that we gave the first batch, that is half the quantity of vaccine that we had out. So each structure received half what it needed for first dose. And after 21 days, that is the interval, we gave the second dose, and it's only for those who were recruited during the first phase. And now for AstraZeneca, it's the same principle. So we make sure that we leave enough doses to cover all those who receive their first dose, and the vaccination staff know that they should not mix vaccine. That is the strategy that we are implementing in the country.
Okay, good. So you are given 21 days interval for the Sinopharm. How about the AstraZeneca vaccine?
AstraZeneca, the countries choose 3 months. So after the first dose, the first dose, the second dose is given 3 months after. Yeah.
Okay, good. So because we are facing challenges of getting supplies because of the anyway, and it depends on where you're receiving, but most of the African countries, the COVAX facility is supplying them through Serum Institute of India, and we've seen that like India also with this upsurge of cases, they definitely had an embargo of exporting the vaccine, and this will definitely have an impact on the second dose being delayed. So I don't know whether you have those in mind, and then planning for the second dose as well.
Yes, all that is taken into consideration, and we are planning. In fact, at the Ministry of Officials at the Ministry of Public Health are having discussion with all these international structures involved in vaccination, in the logistics and in purchasing vaccines, and we are planning based on this information in vaccine deployment in the country. As I said, the strategy is always having half of the doses to make sure that those who receive the first dose will also receive the second dose. But from the guarantee we have received concerning the volume of AstraZeneca that we are to receive, now we are deploying across the country, knowing that the volume that are to become will cover the second dose so far.
Okay, yeah. We know that, like you said, that like the government committed funds to finance the implementation, and we know that like the implementation of this vaccine, the COVID-19 vaccination is not a one-off thing, because based on the number of doses that you are receiving and all those sort of things, the vaccination might go for up to 1 year, or even sometime within 1.5 years or 2 years to say. And then like what are the strategies that you put in place to make sure that like financing of implementation is sustained at that level?
Yeah, the idea is that we may have to live for a while with COVID, and although we are introducing into a sort of campaign in the country, what we are looking forward to is to introduce as a routine vaccine when it after some time. So we'll have about 6 weeks working like this as a campaign focused on COVID, especially But after that, the program is foreseeing an introduction in routine immunization. So we think it will be more sustainable like that if the COVID is to stay for a long time. Yeah. So that's the idea, from campaign to routine.
Okay, thank you. We have a question from Jan. Thank you, Calvin. Are you able to monitor how many health workers or what percentage of health workers are already vaccinated?
Yes, in fact, we have a target in terms of health workers or frontline health workers and those we call assimilate. That is those who work with health workers at frontline. So we had an estimation of about 75,000 health workers. So we can calculate now the proportion of health workers that who have been vaccinated. I don't have the updated figures yet for the entire country, but this is an information that is available at our data management department. So we can, per region, we can have an estimation of the percentage of health workers who have been vaccinated.
Okay, and also from Kiki, I'm just trying to make sure that like I read every question that comes here. Kiki is also thanking you, and then as a follow up to the post that are delivering COVID-19 vaccination, you noted that only 243 sites have been selected to deliver the vaccine out of 3,800 sites in total. These 243 sites that are administering COVID-19 vaccine also still delivering other services such as routine immunization, or are they focused only on COVID-19 vaccination?
No, they are not focused only on COVID vaccination, but the sites for COVID is not the same for routine immunization. So we made sure in this setting, in this post, we have a space where COVID vaccination could be carried out without interfering with the vaccination, with routine immunization activities. But those of the centers are still carrying out their routine immunization activities, although they also offer COVID vaccine in a different service.
And this also boils down to integration of services, like continuity of services as well. And then Kiki was also following up to say, what does it look like in your country? The plans to integrate into routine services.
In fact, we have now trained all district management teams, so they precisely know how to go about managing COVID vaccination, and they know also that we are heading toward introducing the vaccine in routine immunization if it is to stay for long. So these actors have already are trained already, and the only thing to do is just to merge the two separate. That is for COVID vaccine and for routine immunization. But details on this will surely be given. I think as we did for, when COVID started, the program had to develop guidelines for vaccine continuity in the context of COVID. I think there will be very precise guidelines on how to go about introducing COVID that targets adults in the routine immunization. So it is still not clearly defined. We know we are heading to that, but guidelines have not yet been developed. And by the time we get there, the country would surely have developed guidelines to say precisely how to do in vaccination posts.
Okay, great. Thank you very much. Let's come back to identifying the target population. You said that you had issues in challenges in identifying them. We know that, like in the African setup, like we do not have correct database to show us how many people are definitely with comorbidities like diabetes, hypertension, and the like. But also going back, you are also targeting them and vaccinating them. And you are not using an electronic system. And then, like for example, this vaccine, you need another dose to come for a second dose and giving appointments on that. How are you identifying the ones that you have definitely vaccinated for their second dose?
Okay, thank you. So in fact, you just talked about the challenge. That is, how do you estimate those above 50 and above, or 18 and above, living with comorbidities? We have challenge with estimating this target group. And this is one of the challenges that we face concerning the target population. So what we do is that we give them cards, but we also record their contact in the immunization register. So there is immunization register at the vaccination post. They give them cards, they write the date of the rendezvous, and the team at the post also has the contact to remind them in case they don't turn out at the fixed date for the rendezvous. This is what we do so far. We've not got to 21 days after the beginning of the vaccination. It's just about 12 days that we start vaccinating. So by then, I think if there are more challenges, we'll have to sit and design strategies to overcome. Now, for now, we have their contacts. We gave them the cards. We gave them the rendezvous, and we are now expecting them to turn out at set dates.
Thank you very much. And then I think maybe Dennis is also asking if to know how many people have you vaccinated so far in total. But to add to that also, like Ibrahim Barrow is a colleague in Gambia, from Gambia in Sweden. I think he's also asking, how are you mobilizing these target groups for the COVID-19 vaccination? Are they responsive to the vaccines as you expected?
Okay, as I said, there is turnout, but not we still there are still, for now we are targeting helpers now. They are turning out, but some are still behind, waiting to see for themselves if nothing happens after vaccination. So we have some people, some of them are hesitant, and we're working on this. So we have mobilizers that who have been who are part of the vaccination teams, and they also go towards these helpers now to sensitize them so that they get vaccinated. And the other thing also is that at the district level, the DMO have a list of health facilities in their districts. They also have a plan for people to go to the vaccination site, so they can have an estimation of how many were expected and how many turned out. This to follow up with chief of health facilities to encourage their collaborators to go for vaccination. But it's what to be known in Cameroon, vaccination is not compulsory. So we are more of sensitizing people to let them understand that it's very important for them to get vaccinated. And this is how we get them to go to vaccination centers and receive their vaccines.
Yeah. Okay, great. And that's one of the challenges that we are even facing here, mobilizing people to come out for the vaccination. Like, for example, in the Gambia here, health workers, we have some health workers who are vaccine hesitant. They are definitely, as you said, they are waiting to see what will happen to those that have been vaccinated. But so far, we have vaccinated about 60% of the health workers that we targeted. But our major challenge is the people that are in the communities. So what we resorted in doing is like having a caravan, sort of having health PAC, public loudspeakers, mounted in vehicles, and then go to a community, engage the community members, and then talk to them, give them the facts, and allay all the myths and misconceptions that they have. And this is what we are currently working on. So far, so good. We have vaccinated, used over 50% of the doses that we received earlier on. So those are some of the things. And we also have a question from Dr. Puta, thanking you first, and then I just wanted to know if in Cameroon, vaccine hesitancy related to COVID-19 vaccine has negatively impacted other routine services. There are unofficial reports that in some countries, some people are shunning health care services for fear of being given the COVID-19 vaccine. Are you facing this problem in Cameroon?
Yes, in fact, we got this before the COVID vaccine was developed. After the COVID pandemic was declared in Cameroon at the end of the month of March 2020, many people were reluctant to go in health facilities, including for vaccination, because they believed there was a vaccine rumors said that they were vaccines and that the vaccines were to contaminate people with the COVID virus, and people fled the hospitals. Even the campaigns, it was very difficult for us to carry out even polio campaigns because people believed it was not polio vaccine, it was COVID. We were inoculating COVID virus to people. So we could observe a drop in immunization coverage from March to almost July 2020 before the situation got resolved, mostly because of the communication that we did concerning the COVID and what we were doing in our immunization services. So we just introduced the vaccines for real. We don't yet have I don't think we have enough, we've got enough time to analyze data because we receive data at central level on a monthly basis, but we'll also keep an eye on that and do analysis to see how immunization coverage will evolve within this period, and to assess what impact the introduction of the COVID vaccine would have had on the routine immunization coverage in the country.
Okay,
Hello,
great.
hi.
Thank you very much, Calvin. And going back, we definitely almost 8 minutes to the hour, and then we have one point to discuss that are the lessons learned. But just to say that, just to add to what you said about the impact on routine services, like for example, in the Gambia here, we also experienced that. We plan to give HPV a second dose in 2020, but because of the pandemic, schools were closed, and then we couldn't give it out. And then this year, when we started giving it out, because of the misconceptions and information coming out from social media, many people are rejecting, even going to the extent of going to the school and withdrawing their children from the school. We have engagement with PTA, Parent Teachers Association, and the like, and these are some of the things that we are definitely using to engage parents to be able to accept the vaccination. So far, so good. We only have 20% of our target that is covered. But looking at all these challenges, all these strategies that you have highlighted here, what are the lessons that you have learned in Cameroon that you could share with us, like people like the Gambia here and all those other countries that are definitely listening to us in terms of implementing the COVID-19 vaccine?
Thank you. I think one very important lesson is preparedness. Preparedness, like for public health emergency. Cameroon has set in place a public health emergency operation coordination center, and this center has been very useful. I think COVID-19 is the first great public health challenge that they had to manage, and the existence of such a structure has been very instrumental in the way the disease was managed since the pandemic, the outbreak in the country, for the various phases, and even immunization is just a section of the emergency management system that is in place. We also have strong coordination because the government really took the measure of the situation, and the coordination got first at after the Ministry of Public Health, the Prime Ministry, head of government, and after that now we have a task force at the Presidency of the Republic overseeing all activities concerning fight against COVID. And you can imagine the impact on the implementation of solutions. It makes many things easy for health workers to deploy vaccines. For example, we have the assistance of Army in securing the stock and convoying the vaccine in various regions, which is very, very important. We also have administrative authorities that are regional head of the COVID fighting committee, and this is really helping the system to deploy in an efficient manner. We also have keen planning of logistic activities, because after releasing of batches done by the National Regulatory Authority, all vaccines were to be deployed in the regions at the same time. So our colleagues at the logistics had to plan very well to deploy the vaccine, and they were able to do this in such a way that within 48 hours, all regions were supplied with vaccines, and the various vaccination posts could get active. Also, optimization of available information, because we got a micro-planning activities at the beginning of the year. We are updating our SIA immunization micro plans, and these information were used in planning the deployment of vaccines and resources for COVID vaccination. So this optimization of information was also something good that avoided waste of time, because if we were still to go back to the field, start collecting each information for planning, it would have taken much time. And the coordination also helped in developing the plan, and also the intervention of all the actors, because I told you, I previously said, COVID is not only public health. COVID is, most of the department in the government are involved in the fight against COVID. So the strong coordination helped mobilize all these key stakeholders to intervene, to participate in this. And we also have the support of our partners who has been very important for their expertise in helping us developing the plan, but also assisting in training at various levels and deploying the vaccine. So in a nutshell, the lesson learned is preparedness. The existence of a public health emergency operation coordination center has been very instrumental. The strong coordination up to the head of state also has been very important, and keen planning made it possible for us to deploy in a very short length of time the necessary commodities for starting the vaccine. Our first doses were received on Sunday, 1 week ago. Maybe you saw it in media. And on Tuesday, all regions had received the vaccines, and vaccination posts were already operational. So these are some achievements we did, and this is thanks to all I just cited above. Thank you. Hello, Mr. Moderator. Are you still getting me?
Let's see. Has he dropped by?
Mbai is still connected, but the mic is off. Maybe he cannot hear.
Yeah, hello.
Mbai, yeah, sorry, we're trying to reach you. You had dropped.
Okay. No, my mic was muted anyway, unfortunately. You said that, like, okay, preparedness, PHEOC coordination, and then also government buying into the commitment and all those things. Those some of the lessons that you've learned, and then partnership also. This brings me back to a question that Laura asked some time ago, and then I skip it. This is about how are they positioning and engaging with civil society and CSOs for identification and registration of the high-risk adult and comorbidity population in coming months as vaccine supply increases. So, yeah.
Yeah, thank you. Civil society is also involved in. They have been involved in planning this vaccination deployment. In developing the national plan for vaccine deployment and vaccination, and they are also working with us in community for mobilization of the target population. But as I told you, in fact, it is planned. But as I told you, in the first phase, health personnel were first to be targeted. So we think as we are upgrading now, getting to the population age 50 and above, and those living with comorbidity, will have much of their involvement in mobilizing this segment of the community, of the target population, to turn out to vaccination center and get vaccinated.
Great, thank you very much, Dr. Calvin Tonga, special advisor to the BLN, I can say that. Huh? Okay, and then I think you have definitely given us all your challenges, the strategies that you have used to mitigate some of those challenges, and also the lessons that we have learned in Cameroon. And I think other countries also, because Africa and also the globe also is facing some of these challenges, and then we'll definitely learn from you, and then also continue making sure that like the vaccination of COVID-19 becomes successful to all the countries, and so that the world can get out of this pandemic. I definitely want to come to Zambia next year or before the end of the year, please. Okay, on that note, I'll thank you very much, listeners, and then hand over the baton to the host, Catherine. Thank you very much.
Thank you very, very much. A lot of lessons learned, and my goodness, so much to learn from that. And thank you very much for summarizing that very well, Mr. Moderator. And a very special thank you to Calvin for sharing that very informative piece from Cameroon, and also to the audience for the questions. And we would like to, well, I mean, owing to the time constraints, we would like to apologize if we couldn't answer all of the questions, but keep those questions coming on our various platforms that we normally use. Like you can send something to the Google groups, and if you could also drop a line via email if you've got any questions. I'm sure Calvin will be more than pleased to respond to the questions that you may have. And also to let you know that we'll be sharing the recording and the summary of today's discussions. And like I mentioned, this is just the first webinar in a 3-part series. We'll be having the next one on the 6th, and this is exclusively for our French-speaking colleagues. We don't want them left out. We'll be having something there very special so that they can also share their experiences. Unfortunately, we might not have it. We might not have simultaneous interpretation for that one, but if you do speak French and would like to join, just drop the Secretariat a line so that you get an invitation to that one. And also to let you know that there'll be another webinar for the Anglophones on the 27th of May, and we're appealing to everyone. Please, if you'd like to share your experiences, do get in touch with the Secretariat. Please come forward and let us know so that we can plan adequately. And we would also like to invite you to, invite your friends to join these webinars. They're very, very educative. And like we've said, fighting COVID is not just about washing your hands and social distancing and masking up. That's not enough. Let's see if we can all get the vaccinations. They're there. So let's all make sure that we get vaccinated and keep the virus away. Until next time, thank you very much to everyone. So you have a good day or good evening, wherever you're coming from. Bye-bye.
All right. Thank you very much. Bye-bye.
Thank you very much. Bye.
Bye-bye. Thank you.
Bye.
Bye.
Catherine.
Bye.
William Kabore, goodbye.
Yes,
Yeah,
William.
William.
But you want to become a
William, nice to see you. We're connected.
Okay, yeah, merci beaucoup. I'll just stop there. William, merci beaucoup.
Thank you.
Catherine,
thanks.
Thank you so much, Calvin.
Bye-bye.
We're really
Thank
grateful.
you, Catherine.
Calvin, we're really grateful that you took time away from the workshop. Thank you so much.
Thank you very much.
Thank you, everybody. Yeah, it was good.
Thank you very
Kelvin.
much. Bye.
Thank you. Bye.
Thank you.
you.
Yeah, Fred, thank you.
Oh,
Fred,
great moderation.